Recording, and Commissioner Chow, whenever you would like to go, we are ready to go.
Okay, good. Welcome everybody. We're going to call the meeting together for June 28th for the JCC for Zuckerberg. And I'll ask our Secretary, Mr. Moritz, to call the roll.
Yes, Commissioner Green.
Present.
And Commissioner Chow.
Present.
Great. I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples.
Good. Mark, would you call the items? And before we do that, I was just going to comment that on your invite and the agenda, the campus map still shows parking in the site of where UCSF is. So that might be misleading to the public. They find there's a big building there.
Oh, sure. Okay. Thank you. I'll work with Christopher and figure that out. The next item on the agenda is the approval of the May 24, 2022 ZSFG JCC minutes.
Okay, a motion for approval is in order.
Move to approve.
And I will second. Is there any public comment?
There's no one on the line, so there's no public comment, and I'll take your actions, your motion and second as an action, and we can move on to the regulatory affairs report, item 3.
Good afternoon, Commissioners. Thank you for allowing me to present the regulatory affairs report. So if we begin at the top of the report, we have 4 pending surveys, but that's actually not accurate now, as our laboratory survey occurred last week, Tuesday through Friday. And what a great survey that was. We had 2 very engaged surveyors who were incredibly thorough and asked some very hard questions, but the laboratory team really stepped up and were able to demonstrate the great processes that we have. There were 8 findings, which we'll elaborate more on next month, but really what I want to say is that represents less than 0.5% of all of the standards and elements of performance in the laboratory manual. So just a really phenomenal survey for us, and none of the findings were considered high risk or widespread. They were all fairly limited or some pattern in the low and moderate area. So really a lot of kudos to the lab staff in the work that they do and have done over the last 2 years. You know, and I'll remind you that that survey is also a year late. So oftentimes that can lead to people not being as focused, but that was not the case for the lab. Under pending surveys, we of course have some CMS surveys that are pending, and we're just waiting for our state partners to come and do the 4A and dialysis visits. For completed surveys, we have 5. Of note, number 5, the Joint Commission complaint, they received a complaint potentially from staff, but it was an anonymous complaint. So we don't know exactly, the whole nature of that. But it was really, there were some questions raised around whether all of the staff that are involved in work in the endoscopy area have full competency for that. We worked really closely with the leadership in that area and with UCSF Dean's office, and we're able to demonstrate that everyone does have the competency to undertake the duties in that area, and the Joint Commission accepted our response with no further reaction, no further follow-up required. Two plans of correction were submitted since our last meeting. One around a wrong site surgery, and one around a medication error. They're both pending approval, but the surveyor who was with us reviewed these actions before we submitted the plan of correction, because actually they had already been completed. So whilst the surveyors came out, reviewed what had happened after we had reported it, all of those actions had already been implemented, monitored, and demonstrated compliance. So it really was a paperwork exercise to submit that plan of correction with the actions on it. You can see that there's a lot of activity that the regulatory affairs team are doing in those open site visit reports. And there were only 3 new facility reported incidents for the last month. One hospital-acquired pressure injury, one resident-to-resident altercation in 4A, and one fire in a non-patient care area that we reported because it required monitoring for more than 4 hours. We don't anticipate any follow-up required from the fire, and those other 2 events will be investigated under due course. Now, I think there were some outstanding questions around plan of correction monitoring from our last meeting around interpreter use and the process for consent for autopsy. Because our ALCC meeting was deferred last Thursday because the Joint Commission were with us, we'll have a full update on all of the plan of correction monitoring at next month's JCC, so we'll be able to give you all of that information then. No one reported out on those things because we didn't have a meeting. And then the last piece is a new 2567 was received. I know that we communicated with you all via email around a visit we had in May. That visit was prompted by a self-report over a year ago of an event with a Belmont blood infuser. And I know that we've presented that RCA to this group before, and we've had great follow-up from that. But the federal lines of communication aren't as rapid as we would like them to be. So our initial report to the FDA was forwarded to CMS, which prompted CMS to ask the state of California to come out and investigate that. And of course, all this additional work had been done between the initial report and where we are now. So the only deficiency related to that Belmont blood case was around us keeping any equipment, tubing and stuff after an event rather than disposing of it. And that was an anticipated deficiency for us, and we've actually corrected that. Of course, when the state come in as the Centre for Medicare and Medicaid Services, they review certain standards. And they did find us to be deficient in some areas around medical staff services. And again, this was an anticipated deficiency, a known risk for us around OPPE. We have struggled with our OPPE data from being able to get reports from Epic to be up to date with that. And that was really the focus of the finding, was around how we proctor and how we create OPPE reports for our physicians. So again, it was a known vulnerability for OPPE for us. We have a robust plan of correction, which was submitted on Friday. We're awaiting the approval of that plan of correction. Once it's approved, the state will come out and revisit us on those very specific med staff regulations. But I feel pretty confident that we've done the work that we need to do to correct those. There are also some state deficiencies that are outlined on page 4. We don't have the 2567 statement of deficiencies for that yet, but these are the findings that we anticipate. These were not high risk, not high profile findings. And again, the work to correct all of those is already well underway, if not complete. That brings an end to the regulatory affairs report, but I would love to take questions from you all.
Thank you. I also noted that our new Vice Dean has appeared on camera, and we'd really like to welcome her. Thank you for coming. We all know how busy your office is and you are, and we appreciate your attendance at the JCC, and we look forward to your participation.
Thank you, Dr. Chow. Honored to be here. I look forward to working with the group.
Thank you. Let's see, before we take further, there's nobody on the public comment line?
There is one person, so I will ask them. Thank you for checking, Commissioner Chow. Person on the line, if you'd like to make comment on item 3, the regulatory affairs report, please press *3 now so we can recognize you. Again, *3. No hand, commissioners.
Okay, so Commissioner Green.
Yes, well, thank you for the report and for answering some of the questions that I had submitted in advance. The one thing that confused me about page 4, and this should be a simple clarification, is when you're talking about 1 staff member, 2 staff members, was that a random sampling, or is that like in the totality? In other words, was this a spot check, and is there more are there more individuals, or was this like out of 1,500 staff members, these were the I think you're.
This was out. Oh, I'm sorry. No, I'm not mute. This was out of staff members whose files were reviewed during this survey. And I don't have the volume of staff files that were reviewed for each of those, so I'll make sure that we clarify that for next month. But this isn't the totality; it's just out of a small sample. And I will say, though, that I think it represents a very small number, even in the totality. OHS did a lot of work to bring many of these things up to date. So these very low numbers, even in the sample size, I think are quite reassuring.
Well, that's great, because with OHS, everything they've done with COVID, it's remarkable. But that helps a great deal to understand that this is a small sample of a small sample.
So out for next month, I'll make sure that we know what the nominator and denominator is for those numbers.
Thank you.
Thank you, Adrian. I had 1 or 2 questions, and as you were going through, let's start with the CMS complaint validation statement. I assume that actually, is this the same statement on pages 3 and 4? I mean, the same survey?
Yes.
I assume. Okay. And
yes. It was 1 survey, but we received 2 statements of deficiency, 1 based on the federal regulations and 1 based on the state regulations.
Oh, I see. Okay. So, and I think you explained most of it was related, as it says here, to the medical staff. And is that the federal in which we are submitting and expecting a revisit from them, or is that the state then, from the way that you've divided the 2 responses?
It would be the federal, which are the ones on page at the bottom of page 3 that we'll receive the revisit for. The state, I don't believe at this point we anticipate a revisit for the state deficiencies, but we have not received the official statement of deficiencies yet. So there'll be more updates for this group once we've received the official 2567.
Okay, then my let's see. Okay, so that is also the survey that is discussed under page 1, item 2, right? Where you were anticipating deficiencies.
Yes, it's the same one. Correct.
Right, because I got a little confused, because first it said deficiencies noted, and then it said a report, and then it had 2 different agencies. So you've really explained that now.
Okay.
And if we knew that, if I had known that, I wouldn't have had to ask questions. So as to which was which, but very good clarification. I guess my last question is on our open site visits, to which we're not quite getting everything done. And not your fault. I mean, we have a lot of pending visits yet from the agencies. It's number 36. And that was from August of 2021, for which we did have a verbal response of no deficiencies, but we're pending approval. Whose approval are we pending? And now, if I count all the months, I believe we're now in June of 2022.
So what happens is the actual surveyor that comes out writes their report and they give us a verbal exit. And once that verbal exit has been given, that's the state's trigger to present the report to their supervisor. Now, supervisors occasionally will make the report more severe, or they'll downgrade it and make it less severe. So when we receive those verbal exits, they're always pending supervisor review, and that's supervisor at CDPH. My understanding of not just of this office in San Francisco, but of many of the offices, is there's a huge backlog in paperwork. So once we've gotten the verbal exit, it's really a paperwork process for the supervisor to sign off on it and then send us the 2567. Oftentimes a negative 2567, which means there are no deficiencies. So at some point we'll receive notification of that. There was also some conversation. The statewide meeting hasn't occurred this year, but for the last 3 years, we've had statewide meetings where hospitals have gone the first year it was an on-site, but the last 2 years it's been a virtual conference with CDPH leadership from Sacramento. And then the second half of the survey was breakout sessions with your district office. And that allowed us to kind of direct questions to them around things like backlog in paperwork and these kinds of things. And that meeting hasn't happened this year. My understanding is it's going to resume again next year. So those meetings give us the opportunity to address some of these backlogs with our district officers. So there'll be more to come when we know when that meeting's been scheduled. And that meeting is it's facilitated by the California Hospital Association, who are huge advocates, especially for public hospitals. So it's a really valuable meeting to attend.
Well, very good. And that explains also the second one about pending approvals. But thank you. And we'll, or at least I will try to remember what it means.
But we're happy to explain it again. It's the thing about regulatory affairs is it's a very there's a lot of nuance to it, but the thing that there's a lot of structure to it. So it's easy to forget those layers, especially when there's a similarity between state and federal, but there's also differences between state and federal. And that's what we're here for, to make sure that you understand the information that we're giving to you. So we never mind the questions.
Okay, and I do have to say, the regulatory affairs report that you've been all submitting now, maybe for what, 2 years in this format, is really excellent, at least in my mind, and I'm sure in Commissioner Green's mind. It makes it very easy to be able to track and follow and receive information, meaningful information as to the deficiency. So I want to thank you and your office for that.
Thank you, Commissioner Chara. I'll pass that on to Daphne when she's back in the office.
Okay. Shall we go on to our next item, Mark?
Yes, sir. Item 4 is the Financial Stewardship Strategic A3. Looks good.
You can see the correct report, the finance report. I've got multiple screens, so hopefully you can see the leader proficiency in linking financial performance to operations. Good afternoon, commissioners. I'm Jennifer Bossi, Chief Financial Officer, here to present on our Finance A3. My co-lead, Kim Nguyen, as you heard earlier today, unfortunately could not be with us to showcase this work as she's been deployed to Laguna Honda. As always, we start off with our True North Triangle and just remind ourselves our True North goals grounded in equity, safety, quality, care experience, developing our people, and then our focus for today, financial stewardship. I wanted to talk a little bit about our financial history, and in fiscal year 1920, we really began to transform and change our financial understanding and proficiency at Zuckerberg. Prior to fiscal year 1920, the finance reports were simply a payroll and a non-payroll report. with one line for every cost center, simply showing a dollar amount in budget, variance, and actuals without drill down capability. So in fiscal year 19-20, we created a series of 7 different reports to help align our financial data to operational decision making. And that meant creating 2 non-payroll reports, one with active outstanding balance and one closed reports, payroll reports, pharmaceutical, pharmacy supplies, pharmacy contracts, and revenue reports. We worked to create metrics as well, cost per patient day, cost per surgical case, and cost per prescription by integrating some of our Epic volumes. In fiscal year 2021, we gave this information and made it wholly available to our directors and our executive team. And with that reporting in Tableau came a new layer of functionality and drill down, where we were able to give everyone the ability to look at payroll from dollars, FTEs, and hours by cost center down to the employee level detail. And for our non-payroll, everyone was able to drill down to the purchase order or even the item level on the purchase order detail. And this gave our operational leaders an opportunity to understand where they were spending and what areas and opportunities they had where they had control and could improve our financial outcomes. We stood up a series of 19 service line meetings with all of the executives and the directors across the hospital. And in those meetings, we agreed on metrics, interpretation of data, areas of focus, and we developed action plans that we followed up monthly on. Where that has landed us now, and a big achievement for fiscal year 21-22, is what I would call financial integration into our ZSFG culture, and that we have achieved it. And what I mean by that is saying, you know, historically it used to be we would have this variance on a budget report and we would sit down with directors and say what happened. And they'd have to jog their memory from a couple of months back and remember, what did I purchase, what was going on in the unit, what was happening operationally. The finance team is now, thanks to this integration, been offered a seat at the table where prior to large purchases or large changes in operations, we are invited to the table to help build that financial model and create a more sustainable path forward in all of our business plans, regardless of if they are a supplies business plan or a change in service business plan. We've also this year added a contracts dashboard and capital planning sessions, which has been exciting work. So looking into the next year, what does this really mean for us? And fiscal year 22-23 and 23-24 have a relatively rosy outlook for the city. I know, Commissioner Green, you had some questions about the cliff in fiscal years 25 and 26, so I wanted to talk through that a little bit. Our revenues citywide are going to be returning at a very slow pace in terms of business tax, and hospitality. And in fiscal years 22-23 and 23-24, that is masked, and the outlook looks much rosier due to new voter taxes, lower pension contributions, and some the timing of some of our FEMA and federal COVID relief reimbursement. Also, to call out, Commissioner Green, I know you also had a question around the market and the economy and changes to pension. I believe the Comptroller's most recent report is projecting about a 2% difference than the original projection. So looking at what this means for ZSFG in the next year in our problem statement, probably the first time to have this problem in a long time, and that's good, is really stabilization, optimization, and maximizing our revenues. So like every year, we need to meet our budget target and continue to do the work that we're doing, normalize from COVID and really start to figure out what normal life with COVID as an operating hospital looks like and maximize our revenues. So our ongoing operations for COVID that we'll be looking to continue in fiscal year 22 and 23 are a more robust occupational health and safety plan around testing, contact tracing, and navigating our staff through the triage management, continuing to be a testing and vaccination site for our patients, and offering COVID treatment in our monoclonal antibody clinic. Areas where we'll be looking to optimize over the next year is moving some of our project-funded staff to more permanent programs. So in the past few years, you've seen that H58, our overflow unit, has been a year-to-year project. We've asked to make that permanent this year with additional UCSF physician support as well as DPH staff. We also, during COVID, became more aware of the need for a robust building access and security team, and we are requesting to move that from project status to a normal operating status for this year. We're also going to be investing in modernization of our surgical ICU and the care provided, as well as investing in our imaging overread to improve the quality and patient outcomes there. In terms of maximizing our revenues, we're looking in the next year to expand the HIM clinical documentation integrity team and really create a more robust review of our medical records for just their integrity and accuracy in coding. We're also hoping to implement Impella, which will improve cardiac outcomes as well as enhance our revenues, and continue to expand our pharmacy 340B program. The finance team will support and in partnership with operations to monitor this throughout the year by continuing to develop staffing models throughout the entire campus as needed, rolling out this work from the director level to the manager level in terms of our monthly executive finance reviews to help continue our journey around financial proficiency and understanding at the department level how they contribute to the financial gap, as well as what opportunities exist in the revenue arena through our denials management and monthly charges data. So moving into, what are our next steps? Well, this year it's going to be a little bit of a steady state in terms of stabilization and recovery from COVID, as well as supporting the optimization of some of our core services and maximizing revenue. We're going to add vacancy, leave, and registry data to our payroll dashboards to help the operational leaders determine some of their staffing models at a deeper level and a better understanding. And we're also going to add our UC financials at the service line level to mirror our DPH departments, so individual managers have an entire view of their budget on both sides of the house. The future state, we are going to be looking to set our next financial metric for fiscal year 23-24, and we will be partnering with our executive team to determine if that should be denials management, out-of-network costs, looking at new service ventures to improve revenues, CMI, yet to be determined in terms of how we will look to align with the DPH Finance A3, as well as what we feel is an executive priority for Zuckerberg. That is the end.
Thank you. Mark, is there any public comment?
Person online, if you'd like to make a comment on item 4, the Financial Stewardship Strategic A3, please press *3 now to raise your hand. *3 so we can recognize you. No hand, commissioners.
Thank you. I'm just wondering, because this impacts all our staffs and our leadership here, if anybody from the leadership wanted to also help perhaps expand on how this might be helping your own areas. And I know Commissioner Green had a number of questions also regarding finance. So you might think about that, and I'd particularly like to understand how Dr. Ehrlich feels that this is an important tool. It's been talked about for many years. I think they've been trying to put it in for quite a while. It sounds like it's there now, and that there's a whole team really to make it effective. Dr. Green?
Oh, was Dr. Ehrlich going to say something about it first?
Yeah, sure, I can kick us off. I think it's really hard to overstate how important this has been for our operations. My greatest hope when Jennifer came to be our CFO was that we would have a robust and meaningful link between finance and operations to manage the organization. And Jennifer has just done an outstanding job leading that work. It was never the case that managers or directors really understood what was in their budget or why they might be overspending, and that has really radically changed. So I can't say enough about how grateful I am, and I know others are, to Jennifer for leading us through this work. And basically, what she's done is she's created reports and made data visible and created a structure for people to better understand their work. So I can't say enough about this and how important it's been. There are other things that Jennifer's team has done to help us manage operations, like creating staffing models that are tools basically to help managers manage their labor, which of course is the largest percentage of their costs. And we could talk about those at another time, but all of this work has really been essential to our operation. And then I'm happy to defer to others who would like to talk about it more at in their operating level.
Do we have any more volunteers at this point, or we can have you all think about that? Yes, Dr. Fuente, please.
Thank you, Dr. Chow. Feel free, please, to call me Elena. But I just wanted to say that as I am getting used to my new role, that now finishing my second month, I will say I've really appreciated the partnership, working with Ms. Buffy, the whole team, in partnership with Dr. Ehrlich. I think that we are bringing value-centered planning into our process in a way that's very useful, and I think enhances the partnership between the university and the DPH and allows us to collaborate in a better and clearer way. So really wanted to extend my appreciation.
Thank you. I'm glad you made those comments, because I was actually going to ask you what you thought from the university level in terms of really the university contract has, I think, for a long time been a black box to many people, including the commission at times. So like to have heard that you actually feel this openness is going to be very helpful for both of our organizations. Thank you. Anyone else before Dr. Green goes into her usual very thorough questioning of the item, which is a very important item? Thank you. Dr. Green.
Dr. Chow, this is Dr. Marks here. I just like to comment, that what has been accomplished here is just a huge shift in the culture at ZSFG around finance, and that requires really skilled change management. I think that's just a testimony to Jennifer's leadership, not just to have the vision and the strategy here, but to be able to execute on this with the, just huge amount of change management required.
Thank you very much. I think, Dr. Marks, that actually are wonderful comments to remember, because I think for almost several administrations, there's been really a desire to get this, and it's been very difficult to put the information together. And it looks like from this report that you've actually been able to do it, so that we can even discuss some details. So you're quite right that it's been a long time, but it's really great to understand that you all feel that this is going to be very helpful. And now, Dr. Green.
Oh gosh, well, this is really wonderful, and those comments are terrific. I guess the two things I would wonder is, how confident can you be with the projections, and what do you think are going to be really the most reliable changes in revenue? For example, when you really delve into the best revenue capture and denials and authorizations. And then on the other hand, so many uncertainties, everything from labor needs with absences and so forth. And of course, materials costs and shortages. We've had so many shortages, and obviously the prices go up for a lot of the items we need to run the institution. So I'm wondering what your sense is of where you think you'll have really guaranteed wins in this, and where you think we might stumble just from factors out of our control.
Yeah, I think you hit on a number of the factors that are out of our control. What's happening in the marketplace with inflation right now from a supplies perspective, what's happening in the marketplace right now from hiring and the shortage of nurses and the shortages of what we're seeing in other specialty areas like CRNAs or imaging. It's across the board that that's happening. So there are a lot of unknowns that we don't have control over. What we do have control over and what we can do is focus on our core operations and running them efficiently and being smart about our resources and how we use them and when we use them. And that is what the staff modeling and the detailed reporting is designed to do, is give the tools to the managers and the directors to know what their optimal staffing levels should look like every day and give them the plan so that then they can execute on it. I think some of the other areas where we definitely can execute on will be our CDI department. We know, and we've been testing right now, the expansion of our queries, particularly on Medicare and Medi-Cal records. We're currently able to do it through a contract that exists. We want to make that a permanent, not a project funded, not a one-time, and have our staff do that and go from a small percentage of Medicare and Medicaid records having query to all of them, because that's really what's going to improve our revenue in a very ethical and reliable way. Then I think also 340B, we know that has been a very successful program in the last year for us. We believe that that will continue to be very successful. The revenue growth has outpaced what we projected this year. So we expect to see the same next year for that, as well as a lot of the work that Dr. Day and Dr. Zier have done with the finance team around quality outcomes with Impella and bringing that service in to offer it for our patients, not only from the quality outcome side, but it does bring in a bit of revenue, which is a great opportunity for us.
Well, thank you. And I guess the other question I had is, you've got a group of managers, and I'm sure some of them have more facility in the financial aspects of managing than others. So are you giving any classes, or how are you kind of helping managers kind of uniformly understand the terminology and also how to best optimize use of the data you're giving them?
We, when any new director or manager is onboarded, they get a one-on-one session with the finance team. I don't do this in a vacuum. I am very, very lucky to have an amazing, amazing finance team supporting me, and I definitely would be remiss if I didn't say that. They will meet with the directors one-on-one for an intro session into the data. And then we have regular sessions that include not only the finance team, but individuals from our quality team when possible, individuals from our materials team, our revenue team, and all of us are on the phone call to support the manager and the director through any questions that they might have that are barriers to understanding the data and developing an action plan to move forward. And then in addition to that, we make ourselves available. That's the number one thing that the finance team has really adopted and accepted, is to be 100% accessible to all of the directors as needed for any questions, because we do not want to be the barrier to the work moving forward simply because there's a question about data.
Well, thank you. That's really great. Thanks so much for answering the questions.
Of course, thank you for the questions.
I had actually, it was such an excellent presentation. I think my only question related to the modernization of surgical ICU, being that this is a very new hospital. What were the issues found that required changes and the surgical ICU setup?
I am going to defer to my colleague Luke Day, who is much more well-versed in this, because it is actually the modernization of clinical care and not the building.
Okay.
Thanks, Jennifer. Yeah, it's a greght question, and Jennifer's absolutely right. It's the facilities itself are perfect. It's more trying to align all of our ICUs together in line with best practices across the country. And so the modernization incorporates several things. One is ensuring that there is an attending in-house at all the time, or at least a fellow in-house. that there's adequate support to the teams, and that we move to what's historically called a closed model ICU. Currently, our MICU, the medical ICU, is a closed unit, but our surgical ICUs and our neuro ICUs are open. And so we are trying to move to a model where the entire third floor, our entire ICUs, transition to a closed model.
By closed model, are you meaning individual rooms or no visitors?
Yeah,
or what?
sorry, great question. None of the above. Closed model meaning that the way it currently works for our surgical ICUs is that there is one team that cares for all of the patients on the service. So from ICU on down to floor patients. What the trend has been across the country from multiple perspectives, mostly around quality and well-being, is to separate the two. So two separate teams, one dedicated to ICU patients, one dedicated to floor patients. And that's the model we're going to try to move towards. And it has been incredibly successful on the MICU side, on the medicine side. Historically, we get very good reviews from an educational perspective. Our quality outcomes are quite good in those areas. And we think there's better transitions of care when that model is followed. So we've always wanted to move towards this. It's just we're doing it incrementally.
This is slightly off the topic of the surgical ICU, but in that model, then you have two different teams. So in terms of the patient, then is there a loss of the continuity of care? They have to then get used to a new team, or is this it sounds like you're saying it's actually better, but this kind of says that one team is constantly under a great deal of pressure, right?
So excellent point. As with any model, there are always trade-offs, and this is one of the trade-offs in this system, in that there have been concerns raised around sort of continuity of care, but really handoffs. We've developed several communication tools to improve that. So especially in terms of when a patient goes from the ICU to the floor, that there are standard processes we follow in terms of information that's communicated between the teams. On the flip side, when we've had only one team caring for patients, from ICU to the floor, there have been concerns raised around just the volume of work, the complexity of work, that people are moving from one unit to the next quite quickly. And that it creates more discontinuity of care and more fragmented care. So that's why the closed unit, and when it's been studied, has been shown to be a little bit better in that respect.
Understand. Dr. Green, any comments on that? I noticed you were nodding your head. That sounds like the model I think even UC uses, but I don't know if CPMC is doing that on your ICUs.
Yeah.
Interestingly, ICU or UCSF is just going to a closed ICU this year.
Yeah, I think it's separate. I know NICU, I think it's separate teams.
Oh, okay. I think my experience was that I believe they were separate teams in the cardiac unit at UC also. So, and realized that your staff was actually following them all the way through, which I saw might have been a patient advantage, but it looks like the idea here from your understanding of the literature and experience really shows that a separate team is probably better for results and for patient care. So sounds very good.
Commissioners,
Okay. Yes.
Commissioners, if I might, we are very lucky to be joined by Christina Bloom, who's the nursing director for critical care. And I was going to introduce her in a moment, but Christina and Jillian Otway are covering for Terry D'Antoni while she's away. And so Christina is here. And I thought I would just invite her to talk about closed versus open ICU from her perspective.
Oh, very good. Wonderful. Thank you for bringing or volunteering her to speak on this. Thank you.
Thank you so much. I think I have to agree with everything that Dr. Day has said. We call it closed. There's probably some better language for that, but the concept of having physicians who are specifically trained to ICU patients, take care of ICU patients, is really considered best practice around the nation. And so we want to be able to provide our patients with the best care, and having doctors who just take care of ICU patients day in and day out is seen as the best way to take care of critically ill patients. So we're really excited to move towards that model. And I know Dr. Day and Dr. Cucchieri, who's our chief trauma surgeon and also our interim chief of surgery, have been working hard on moving us towards that model.
Very good. Thank you.
We're anxious for
No,
the change.
I appreciate that, and it gives, I think, all of us a great understanding of what you were all, putting in place here, even though under finance. So it's wonderful how finance then, and we do know finance affects quality, and certainly can enhance it or make it a real problem, right? So.
Agreed.
Thank you very much. Are there any other comments from anybody in terms of this topic? If not, thank you for a wonderful presentation. And Mark, we can go to the next item.
Sure. Item 5 is the ZSFG Chief Executive Officer's Report and the Emergency Department Newsletter.
Hello, Commissioners. So delighted to be here with you. I wanted to start just by introducing some folks who we introduced a little bit, but wanted to introduce them and also explain how we've been supporting Laguna Honda. So first, just to reintroduce Chris Ross, who normally is our strategic guider in the Kaizen Promotion Office. He's been helping us and really leading our work in strategic planning and Hoshin. He has graciously agreed to take on some of Kim Nguyen's tasks while she is supporting Laguna Honda, and specifically supporting this meeting, as well as a number of other high-level executive meetings, expanded exec management forum. So I'm very grateful to him for that. Secondly, I wanted to reintroduce Christina Bloom, who, as mentioned, is our nursing director for critical care. She and Jillian Otway, who is our nursing director over labor and delivery services and our NICU and PEDS, they are covering for Terry, who, of course, is acting as the chief nursing officer at Laguna. Terry is still the chief nursing officer here. She is always reminding us of that. And Christina and Jillian have just been incredible supports for her and for the rest of the team. And then last but not least, Dr. Elena Fuentes-Affleck. This is her first JCC meeting. That was surprising to me to learn that earlier today. It feels that she's been with us for longer than that, but very grateful to be partnering with her as the new vice dean for UCSF at ZSFG. We have other folks who have been deployed over at Laguna Honda, either full or part-time. Our Chief Communications Officer, Christine Falvey, is there. Iona Johnson has been helping quite a bit with staff experience, as has been Jeff Critchfield. Our quality team has been intermittently involved over there. So we're doing everything we can to support them through the recertification process. And I'll speak a little bit more about that in the context of our report. I'm going to skip over the COVID #1 because there's not a lot that's new here, but there's more we can talk about in the context of the data. So in May, we were celebrating Asian American and Pacific Islander Heritage Month, and in June, we've been celebrating Pride Month. I wanted to compliment the Health Commission on your very detailed proclamation about Asian American History Month, and I felt or Heritage Month, and I wanted to share that. So it was a topic of my CEO note one week, and especially I appreciated the history of the different folks in San Francisco who are Asian American or Pacific Islander who have contributed to our society and culture. Pride Month is a great opportunity to shout out our facilities and garden team, they have a poetry walk, which is really outstanding. They do so many things that I think, often go unnoticed on campus, but if you have the chance to walk the campus and see the poetry this month, it's well worth it. Our occupational health team, you had called them out before. I can't say enough about how much good work they do. They've also been publishing, and specifically here, they published a paper about the ineffectiveness of temperature screening for COVID detection among healthcare workers. I love studies that demonstrate things that don't happen as well as ones that do. We had a big celebration, as you can see from the photo, for National Gun Violence Awareness Day. We have just a remarkable team here who is really dedicated to not just taking care of patients who have been injured by guns, but also advocating to try to minimize the impacts of guns over time. And then we have Daisy and O'Connell Society Nursing Awards, and there's a really nice gallery of awardees in my report. The last thing I wanted to say is our wellness center, and I really want to applaud them for thinking creatively about how to address staff well-being. This is a national issue for the healthcare industry, as I'm sure you all know, and they are hosting a well-being conversation series, which is, another way of trying to understand better what will be most supportive to our staff. I'm going to move on to the data now. So my favorite COVID chart is the one that shows, it doesn't really show the first surge, but you can see sort of the impact of 5 surges. Now we are in our 6th. And there's more to say about that as we go through the report. With respect to the emergency department and the average daily admissions, you can see that those are stable relatively over time. But the next charts, which show leave without being seen and diversion rate, really, this is the reason they've been staying stable, is because we've been on diversion a lot of the time. And that is mainly driven by staffing, both vacancies, people being out with COVID and with other things and being on leave. And we've really struggled with that, as you can see, over the past month. I anticipate that these numbers will get better for the month of June, but these are not numbers that we would be very proud of. It's just we've been really burdened by staff outages over the past month. Urgent care has been a remarkable key to helping the emergency department and the rest of our patients. You can see that the average daily encounters continue to go up. I think they saw 133 people in urgent care yesterday. That is, a lot of that is the transfers from the ED to urgent care for patients who don't necessarily need to be seen in the emergency department. Transfers going the other way have been mostly flat, which is good. That's definitely what we would like to see. Moving through the report, the numbers in PES and inpatient psychiatry have been relatively stable. And I did want to call your attention on page 15 to the ICU average daily census. What has been interesting is that, we really haven't been overwhelmed in this surge. And if you look at where the census in the ICU was highest, which is back in January of 21, that was really before we had the impact of vaccines. And so in some ways, I think about this ICU volume being mostly stable is thanks to COVID vaccines, because people have not been as sick with COVID. MCH volume is going up, and that is good to see because we want to take care of more moms and kids in the hospital. Dr. Green, last time you asked some questions about what happens when other hospitals go on divert, and we provided that information by email. Let us know if you have any questions about that. But we've been able to accommodate other hospitals that go on OB diversion pretty well. Sometimes we have to go on diversion, and then it's the process in the other direction. But mostly we're accommodating people from UC. Okay, so on lower level of care. Now this is the graph I wanted to pause on because Dr. Green, you commented on this, the skilled nursing I wanted to put on this filter so you can see really clearly a trend up in our lower level of care patients here. And that is really entirely, well, it's due to a couple things, but the Laguna Honda situation is a big player here. And Laguna, either because of COVID or because of the current situation, has mostly been closed to us since the very beginning of the year. And you can see the trend upward in lower level patients since that time. So I think there's a pretty clear correlation. There are other things that impact lower level of care. It's been a chronic problem for us, as you know, but the Laguna situation has been really challenging. That being said, I think we're doing everything we can to work very closely with Laguna on this. It is a fact of life that when we can't discharge patients to Laguna, and when Laguna is discharging to the same places that we need to discharge to, that is a problem. And there is no magic bullet for that problem, because there is and has always been a limited number of SNF beds and other lower level placements for our patients. But our care coordination teams meet with each other every day. We have a weekly meeting on Wednesday with leadership. So it's typically Claire Horton and I who meet with them to see if we can bust any barriers or do any kind of facilitation for moving patients out of the hospital. So these numbers are concerning, and at the same time, I think we're doing everything we can to ensure that there'll be as little impact on ZSFG as possible, and that we're facilitating discharges from both places as well as possible. I think I'll pause there and see, what questions you have about that that we could address further, or about anything else I've talked about so far.
Are there questions, or did you? I'm just looking as to when we might ask the public.
I think this is an appropriate time. I'll check in with the public, Commissioner.
Okay.
First on the line, if you'd like to make comment on item 5, the CEO report, please press *3 now so we can recognize you. Again, *3. No hand, commissioners.
Thank you. Commissioner Green, further questions on the report?
Yeah, well, this is very elucidating, and this lower level of care question is just a very difficult to solve conundrum. This may be a really naive question, but when you've got lower level of care patients in the hospital that you're not being compensated for, compared to if they could go to Laguna even though we're not going to be paid for admission, which is more expensive? In other words, keeping them in an acute hospital setting versus Laguna. I mean, if they're all patients of the system, and ultimately money is going out the door covering these people by the system as a whole.
Yeah, it's really complicated question. It depends on what their coverage is, if it's managed care or fee for service. It depends on what, the impact, the overall financial impact depends on who then reoccupies those beds, what patients come in that you can bill for or not. So it's complicated. I don't think we have a good financial analysis of that circumstance. I would invite Jennifer to comment on it if she has anything to say, but on the face of it, it's more expensive to keep them in this hospital than at Laguna, but there are many other factors to consider.
Thank you.
Did Jennifer want to add anything to that from the financial side?
She's
Jennifer, you're on mute.
I wanted to just echo and agree with what Susan said. On its face, yes, it's much more expensive to have a patient in an acute care bed. We most of the time are not reimbursed for those days if they don't meet interqual criteria and don't need inpatient. And so it's a loss of revenue, and it's also more expensive care in an inpatient setting. But to Susan's point, it does depend who comes behind that patient and where the patient is placed, and how we fund the placement of that patient as well.
Are there ever appeals on lower level of care where you actually, there's a change in reimbursement, or is that just a lost cause?
I don't think we do much appealing, but I would be happy to get back to you with more information about that, unless Luke, you have something more to say on that one.
I do know we can
Or
appeal it.
Jennifer.
The other thing too is that sometimes our lower level of care patients become acute again if they have stayed long enough in the hospital, unfortunately. But I do know in some cases we have appealed decisions on it. Usually it's for a couple of days. It's never for the extended period of time that they're here.
Thank you.
Looking at the lower level, which we have, and I thought that was interesting from Commissioner Green to discuss whether or not could we, in fact, place patients over at Laguna and not get reimbursement, or are we even allowed to put patients over in Laguna?
Laguna has not been taking any new admissions. They will take readmissions of patients, but they have not taken any new admissions. And the reason for that is because they really, I mean, they're doing a huge amount of work over there to become recertified. So that, that takes up time. And the other thing is, as you know, they are not certified right now, and there's a lot of pressure for them to discharge patients. So there's a parallel track of work that's going on. One is to discharge patients because they are not certified by Medicare and Medicaid, and the other is to become recertified. So we have, as I mentioned at the very beginning, we haven't admitted any new patients to Laguna really effectively since the beginning of this year.
Are there any opportunities? Well, I guess you've set them aside here. Is there any way, like you did your skilled nursing facility, to use a lower level of staffing for this population, or do we actually do that at this point?
That's not allowed. If a patient is on our med-surg service, they have to be staffed according to state nursing ratios and MOU ratios. It doesn't matter what level they're in. So for example, if they're in the ICU, we have patients at med-surg level of care in the ICU. They still have to be staffed 2 to 1. Now, we do have 4A, which is a skilled nursing facility in our hospital that we use very effectively to try to move patients off the acute care service. But we only have 30 beds, and we keep it as full as possible. And the data that you get reflect that.
Right. Okay. Well, maybe we should expand skilled nursing here. But no, I guess that would be in contradiction to what we were trying to do with Laguna, rather than just here. The COVID numbers that we're showing here is the same question that we've asked a lot of times. Is that are those primary COVID, or they're inclusive of COVID cases that were admitted for other reasons?
I'll let Dr. Winston answer that question.
Thanks, Dr. Chow. They are inclusive of COVID cases that were admitted for other reasons. As we've mentioned, it's a little bit complicated because many times, even if COVID is not the primary reason for admission, it is contributing to the illness that led the patient to be admitted. So those are inclusive numbers.
Okay, I was pretty sure they were, but as I was looking again today, I thought, well, I should clarify for sure that I know the overall city numbers were inclusive of it, and I just wanted to confirm ours are being collected in the same way. Thank you. Well, thank you for this report. And are there any other questions or comments related to it from anyone?
I did want to just mention 2 other things. One is the occupational health data. This has been a source of challenge and frustration for all of us, because unlike every other surge where we had a rise in cases and a fall in cases, this one, as you can see from the data on page 22, we've been on this mesa for a very long time. And every day, our occupational health colleagues are diagnosing 20 to yesterday 33 new cases of COVID among the DPH staff, most of whom are here at ZSFG. So you can imagine this represents a really significant challenge for our workforce. And the other thing about this is that this is unlike previous surges, this is really mixed among our provider staff as well as other staff. So and we're not sure when this is going to end, to be honest. So this just for your awareness, this has been a really tough thing for us to manage. And then the last thing I wanted to just point out is that on page 23, we have our workplace violence activity. And as I've mentioned, I've been very reluctant to comment on this because there are a lot of issues with, we know, with these data and how complete they are. But we have put a huge amount of effort into addressing the situation. And you can see that there appears to have been some impact over time. And this relates to a question that you asked Commissioner Green about CPI training and BERT training. And as I was reflecting on that question, I think they're very similar in their focus, which is about recognizing patients who may have behavioral challenges. And so noticing it, de-escalating, and being very aware of how one's behavior, the staff person who's being trained, how their behavior impacts the patient. And the difference between CPI, which is really for all staff, and the BERT training is kind of the difference between, basic training and specialty training. Because the BERT team is a specialty team made up of LPTs and psych nurses who are specialists basically called to the scene, right? If you think about what the BERT team is, it's Behavioral Emergency Response Team. It's synonymous with our Medical Emergency Response Team. The purpose of that team is to prevent a code blue. Purpose of the BERT team is to prevent an escalation that will result in injury or harm or calling the sheriff's department. And so they're similar in what they're trying to focus on, but different because we're talking about all staff in the case of CPI and a specialty team in the case of BERT.
Right. I didn't realize, but I see now that the occupational health stats are across the department, and I know that we had been noting as we get reports daily on the Laguna Honda staffing that there definitely seems to be different this particular surge where our staffs continue to be impacted, which is then affecting some of the patients over there, and to realize that this is actually a virus that now seems to be really continuing to affect an awful lot of people, and many reasons for that, of course, right now. But fortunately, as you pointed out, while the hospitalization has stabilized at a high level, actually, throughout the city, not as high as we've always had, but I think still having about 100 COVID patients per day in San Francisco is definitely higher than when we were down to just 20 or 30 maybe throughout the city earlier before all this happens, and this kind of parallels it. I was wondering from your report if we are using temperature checks after such a report came out from occupational health, either here or anywhere in the department.
Oh gosh, I can't remember the last time we did temperatures. It was more than a year ago. I don't know, Lisa, do you remember exactly when we stopped doing that?
I can't remember when we stopped doing it, but there were some other reports in the literature that it was not effective, and then our team reviewed our data here, and we weren't picking up cases by using that. So we are not, as Susan said, as Dr. Ehrlich said, using it here. I can't say for sure whether it's being used anywhere else. But I think not to screen staff within DPH.
Okay, thank you. Appreciate that. And If we have no further comments, then I think we could proceed on to our next item. Mark?
Yes, item 6 is the ZSFG hiring and vacancy report. Ms. Hill is here.
Hi, good afternoon, commissioners. You have my report in front of you. There's a couple of things I want to highlight. So first, Commissioner Chow, you requested for kind of a more definition about the notes. And so we added that to the last page of the vacancies over 10%. And so under the note, and it gives kind of like a detailed description. So I wanted to, for you to review that and let me know if this is sufficient. Otherwise, we'll make more adjustments for the report next month.
Okay, yeah, you want to make a comment there? I was just, the notes are very helpful in terms of the definitions, and what I had thought was not so much that you had to put it in here, but whether you could actually discuss how long each of these phases took on an average. In other words,
Okay.
You see what I mean in terms of,
Yes.
if we run through all 5, does that take 2 years or 1 year like in the past, or have we been able to shorten some of these times, or um, just kind of giving an average understanding? So it's, but no, I was going to make a comment to you already that really appreciate you putting those in, and I would put that definition each time so that we can remember what it's all about in terms of the definitions of your status.
Okay. And so we'll look into see if we are able to provide a timeline. I know each, for one position, we probably are able to define, but when we have multiple positions, they're running, the vacancies are in different phases, right? So some vacancies are under different hiring managers. So the timeline may differ for each vacancy because it's not each, for example, a health worker, we have 4 positions, 4 vacant, but those 4 vacancies could be under different hiring managers. So the timeline may differ based on the hiring manager, their timeline.
Right. So I understand. Maybe it's not possible to say phase 1 is always between 3 and 5 months. Maybe
Got it.
it's more by categories of the types of service we're looking at, and more, kind of a description to us, like clerical takes 8 months or 10 months, but when we do nurses, we can get it down to 3 months or something like that. I think that's the practical side of trying to understand the phases.
Perfect. I will make those adjustments and try to categorize the vacancies and break it down to provide a timeline.
Thank you.
Okay, great. So a few of the highlights, you have the summary report in front of you. So a few of the highlights were the hiring event we hosted last month. We had approximately 120 applicants that showed up during the hiring event, and different specialties were present. And this was not just for Zuckerberg, but this was across DPH. And so they were, all 120 applicants were interviewed. And those 120 applicants did include P103s that we interviewed as well. We were able to convert 8 P103s into benefited positions. Some P103s were offered positions based on specialties they qualified for, but they wasn't actually interested in those. So a lot of per diem showed up for positions of which they didn't meet the MQ, so we could not consider them for those positions. But we did interview about approximately 20 P103s and made offers to 8. And out of the remaining 100 applicants that were not P103s, we made 21 offers and into vacancy. So this was great that we were able to extend offers to several of the attendees. The remaining attendees that were interviewed will remain in our applicant pool. But as soon as vacancies open up, because they were interviewed already, hiring managers can make immediate offers. So we're excited about that and hoping to have more offers made as the vacancies open up and as the new positions come in the next fiscal year. So those, and then also we have our next ED training class will be starting August 8th, as well as our ICU class was scheduled for June 13th. However, we postponed that to July 9th to include the new selections that were made. And then, so we delayed the class for a couple of weeks to include those new offers. And so they're in the process of being onboarded, and we're hoping to have them, their targeted start date pending all clearances to begin July 9th. And so that it concludes my report. If you have any questions, I will answer them.
Okay, Mark, can we ask for public comment?
Sure, there's some folks who've joined. Folks on the line, if you'd like to make comment on item 6, the ZSFG hiring and vacancy report, this is the time. Please press *3 so we can recognize you. Again, *3 to raise your hand to make comment for item 6. I'm gonna wait a minute or two, a few seconds, just because I feel like folks might have come on for this report. Although I don't see any hands. So go ahead, commissioners.
Thank you. I note that the RN bargaining has reached a tentative agreement already, and is that correct, without anybody storming us?
Yeah, it was tentative as of May 27th. I believe a final, as since then, there's been a final agreement that's been made that should go in effect July 1.
Wonderful, thank you.
Yes.
Commissioner Green, did you have some questions? Because I had one more definition question. Sorry, but
Yeah, well, first of all, it's wonderful the hiring events have gone so well. That's terrific. And there's just one thing I didn't understand, and that is at the very end with your BERT hiring trend, it seems like you go 6, 7, and terms of filled positions, 6, 7, 8, 7, 6. And so I was wondering what happened to the positions. I mean, were positions filled and then someone decided they didn't want to do it? I mean, it's just small numbers, but I'm wondering how that kind of trend happened.
Well, so what happens with the BERT, they have to go through another level of clearance. So sometimes we lose these candidates while we're onboarding. And so while offers are extended and we can report that offers have been made, some may drop out during the onboarding or offer process. So those numbers can go up and down depending on the time it takes to clear. And it takes, sometimes 90 days to clear, if not more, because of the background.
So are these people that just decided after seeing what the job entailed that it was too much for them, or they want to do something different, or are these people that have had background issues where once, because we are kind of fast tracking people?
No, not necessarily, because they may drop out because the process is taking too long. And some of these processes are beyond our control, like the clearances they have to obtain to work for these specific positions. So, some just may, change their mind during the onboarding process.
All right, great, thanks. That's all I wanted to know.
okay, I had my definition question was under your RN hiring status, and I have just maybe you can remind us what is the difference between experienced vacancies versus training vacancies?
So there actually is one vacant. It's one vacancy, but we kind of split up the vacancy to determine if we're going to hire an experienced nurse versus a training nurse. And so those numbers kind of roll up to one to one whole number. All of those vacancies, like for ED, for example, like the ED, for example, has 35 vacancies, for example. And so they've broken up those vacancies to hire 15 experienced nurses and then dedicated the 10 to training. However, if we get more experienced nurses, like more than the 15 experienced nurses, we can change those 10 positions that's been identified for training. We can change those specialties into an experienced nurse, and vice versa. Experience can be changed to training if we get more qualified or interested applicants in the training. They all roll up to one number.
Okay, so it's one opening, and then you first specify whether you really want somebody experienced and not go through training, or there are certain numbers that can go through training, but we're flexible within it.
Yes.
Okay. All right. Thank you. Oh, I guess my last question was under your hiring events, you talked about a new grad hiring event in the early fall.
Yes.
And I'm wondering if that's late regarding when people have been looking at perhaps jobs as they are going to graduate rather than after graduation.
Yeah, so we try to time these events around the time that they graduate, which is around May, and then they take their boards that they usually obtain somewhere around July, and then we can host an event come August, right? August, September. And to your point, yes, they may already be looking for jobs, but the problem is they can't apply for any of our jobs unless they have the MQs, right? So even if they submit an application and start submitting the application early, they're going to be rejected. And so we don't want them to receive a rejection, right? Then they may, when they do get their boards or their qualifications they need, they may not decide to reapply to us because they've already been rejected. So it would be better for them to have all of their requirements. And then what we'll do is reach out to the entire pool and then invite them to an event and have them apply that way. So we're capturing them at that time. And prior to Terry being deployed to Laguna, we spoke about the grads that was part of the resident program that Zuckerberg hosted a few months ago. So they already have a pool of a little over 100 that we're already ready to to invite them to this event that we're going to have in the fall. But we're again trying to time. My understanding from Terry is that this pool will be ready to go with boards after July, around July. So then we can start scheduling them to invite them personally, give them personal invites rather than wait for them to apply, that we can just send invites out to them, to this whole group personally, to invite them to our hiring event, and then have them apply like a week or two before the event, so they're already in our applicant pool, and then we can consider them for our vacancies.
Okay, so did I then understand that prior to their graduation, they are made aware of jobs that could be looked at general after they get their license?
Yes, that was the communication that was made from Terry and Jillian at that time to that group that we'll be hosting an event. I believe they've already been notified that we're going to be hosting an event late in the fall. So hopefully, like I said, we can't guarantee that they will wait during that time, just to your point, but they have been notified if they're interested in Department of Public Health that we'll be hosting an event in the late fall around August.
Okay, looks like we're hobbled in terms of trying to capture people, but at least you have sort of indicated to them that there could be jobs here.
Yes.
Okay. Are there any further comments or questions on this report? And if not, Mark, can we go on to our next item?
Of course. Thanks, Ms. Hill. Item 7 is the medical staff report. Dr. Winston.
Thanks so much, commissioners. It's a pleasure to present the medical staff report. There are a few items on it today, so I will try to go through those in an organized fashion. So the first item for your information is the clinical service report from otolaryngology and head and neck surgery. We're not doing the updated rules and regulations today. Those should be coming at the next meeting for approval. But on this report, first of all, I just wanted to point out a big thank you to our departing Chief of Service, Dr. Marika Russell, who decided to move on from us. Unfortunately, she's going to pursue additional training in Boston. But as one of her, at the very end of her tenure, she did a really beautiful clinical service report that I think helps to set up the service for success for her successor. And Dr. Patricia Loftus has been named as the interim chief of service. So you'll be hearing more about that going forward as a search committee is formed. And on that report, I just wanted to address 2 questions from Dr. Green. Thank you for submitting these in advance. But Dr. Green had a question about the fall in no-show rates and whether that was related to the Saturday clinics. And Dr. Loftus kindly responded to this. So the Saturday clinics were really successful in helping to decrease the TNAA, the time to next available appointment. But in and of themselves, they probably didn't decrease the no-show rates. Although attendance for the folks who were scheduled for the Saturday clinics was excellent. But the thought in the department is that what really helped with that was when their clinic staff were able to call people ahead of time to remind them about their appointments. And so they hope they have the bandwidth to continue doing that because they think that was very helpful. And then the other question I think Dr. Green had about that was what is being done to screen people at high risk for ENT malignancies, including HPV-related nasopharyngeal cancer in Asian Americans, Pacific Islanders, or oral cancer in smokers. And Dr. Loftus responded, as far as she is aware, and also as far as I'm aware, there aren't recommendations to do primary screening in the US for those conditions. But what they do is that for any patient who is referred for any head or neck complaint, or if there's a concerning imaging finding, they do a complete head and neck exam, and they book folks as quickly as possible to be seen in clinic if there's any concern that there may be a cancer diagnosis. So I will stop there and see if there are any questions related to the otolaryngology head and neck surgery clinical service report.
Commissioner Green, did you have further questions for that part of the report?
No, that's really very helpful. I think they were really answered. Thank you.
Thank you. I just was wondering first. It sounds like it's a fairly small group, and just wanted to know how many. I guess how many personnel or professional personnel are part of this group, and it sounds like they do an awful lot of work with a very small staff.
Yeah, I think that's right. I mean, before Dr. Russell departed, they really only had one full-time FTE, who was Dr. Russell, who was here 100% of the time. And then as she kind of goes through and outlines, they've been very fortunate to get support from UCSF with their providers coming over. Kind of as small parts of their FTE or volunteering to see patients here. And the other thing that I think UCSF has been very generous with is that the OHS providers at UCSF take call over here to cover the call to make it reasonable. But you are absolutely correct. It's a very small department.
And so when it reads that there are 2 non-ACGME fellows, what does that imply?
Yeah, so non-ACGME fellows are credentialed here as attendings for their core work in what they've completed residency in. So in this case, OHS, but then they can be pursuing further training under supervision of the attending clinicians. So they can both, provide some core services in addition to what they're doing under training with, attending supervision as any fellow would have.
Well, do they then get the same qualifications or can go on to the subspecialty perhaps that they are training in? Or um, I'm trying to understand the differentiation as to why there would be a non-ACGME versus an ACGME program.
Yeah, so some fellowships are ACGME fellowships, and some just are set up so that they are not and are not under the same kinds of provisions and rules as the ACGME fellowships. There are also circumstances, particularly in medicine, where you might be an ACGME fellow for the first part of your fellowship, often your first 2 years, but then you might continue on in fellowship subsequent to that as a non-ACGME fellow. But many of the surgical fellowships are not administered under the same provisions as the ACGME fellowships. They still have to meet a lot of requirements, but they are set up a bit differently.
Okay, and they get the same types of recognition then, or can apply for the same types of whatever one applies for your ACGME versus non?
Well, I think the processes for application are a little bit different in terms of, whether there is a match for when you apply, into your specialty and whatnot. And that may vary by the different departments that have these. I am, of course, most familiar with the ones in the Department of Medicine, but they they're all valued fellows.
Okay.
And they are all supervised. But one difference on the medical staff side is that all of our non-ACGME fellows are credentialed through the medical staff department. So they do undergo credentialing, whereas ACGME fellows do not have credentialing.
Okay. All right. As long as it's sort of the same training and the same expertise, and they are recognized for their skills in the same way. All right. Thank you. I did. Let's see. We haven't quite completed your presentation, I guess.
No, so if there are no further questions about the service report, I will move on. And the first thing to discuss is the standardized procedure for pediatric urgent care. And, I first, again, want to thank Commissioner Green for her detailed questions pertaining to this. And then I also really want to appreciate Dr. Sean Jane, for helping me to answer those questions in a clear and comprehensive way. As you may recall, when Dr. Fuentes Affleck assumed the vice dean position, Dr. Jane became our interim chief of pediatrics. So she helped to address this, since the standardized procedure is from their department. So the first thing Dr. Jane thought would be helpful to know is that, kind of the purpose of the RN standardized procedure is really to expedite the care of patients who are presenting with straightforward, commonly encountered conditions in pediatric urgent care, to empower their nurses to start the workup without having to wait for MD or NP evaluation. But the standardized procedure is not meant to be, fully comprehensive of all the care that the children may be getting while they're in the clinic, nor does it, talk about the complete workup, as the RN, all the patients are going to be seen by a provider, and that provider is going to be responsible for the workup they get. So she thought that was, kind of helpful to, set the expectation for what might be found in the standardized procedures. So then just to go through the questions specifically, is there any place in the pediatric protocols regarding patient confidentiality? And Dr. Jane said yes. For all patients above the age of 12, the provider, either the MD or NP, must have a conversation with the patient without the parent or guardian in the room. It's a routine practice done for every patient, regardless of the presenting complaint. And it's really protocolized at the MD, NP provider level and not at the RN stage of triage, which is what the protocol addresses. And if the patient discloses confidential information, they have a very specific way that they will document it. The RNs do not document when sensitive information is offered in the EHR. They pass anything they're concerned about to the provider, who will then follow up with the patient and document it. So then the second question turned out to be very complicated, if the first one wasn't complicated enough. So Dr. Green was wondering, at what age does a minor patient have a right to privacy? And Dr. Jane informed me that this is very nuanced and actually depends on the type of service offered or what type of history is elicited. And that their adolescent health working group has created a very detailed document to support the privacy considerations in the state of California. And the providers reference this when they make decisions. But because it is nuanced, and since the final decision to treat or not to treat rests with the provider, they elected not to include it in the RN protocol. So then the third element of that question was, without clarity, the statement, quote, if able to protect patient confidentiality, ask about use of contraception, unquote, could be ambiguous, and given Roe's demise, may be even more critical. And Dr. Jane certainly agrees that the question is critical among adolescents. And just wanted to say that the specific protocol is to address the questions that the RN would ask to expedite care, and that the RN may ask about contraception, but if the RN does not or is unable to do so, for example, if the parent is with the patient or the setting is not confidential because others are in proximity, the provider carries the responsibility for asking the patient about this. And she pointed out again that the routine practice of the provider is to perform, in a medical colloquial term, a parentectomy, to make sure that they are discussing confidential matters with the patient. So hopefully that addresses those questions. But I'll finish with these and then see if there's anything additional. So then another question was on page 14. Many female patients with UTIs also have sexually transmitted infections, and the UTIs might be secondary to intercourse. And Dr. Green didn't see anything in the protocol suggesting cultures or tests to rule out sexually transmitted infections. So Dr. Jane pointed out that they routinely screen all patients who are older than 15 as standard of care for chlamydia and gonorrhea in pediatric urgent care. Depending on the history, they may also test for trichomonas, HIV, syphilis, mycoplasma genitalium, and HSV. And that STI screening is already covered in a separately approved standard operating procedure for ambulatory care that applies across all clinics. And that the current document is specific only to pediatric urgent care and is somewhat more limited. So that's why it is not in the SP. She also pointed out that the decision to test younger patients would rest with the provider. and, wouldn't be covered under a specific protocol. And then I think the last question, where are the protocols for adolescents or children who might have findings other than trauma that could indicate abuse? UTI and abdominal pain come to mind, and some patients might feel more comfortable speaking to a nurse than to a physician. And so Dr. Jane noted that when a patient discloses abuse or concern for abuse to the RN in urgent care, or if the RN suspects this might be an issue, that the RN will, expeditiously communicate the concern to the attending MD, and the MD is responsible for evaluating it, determining the likelihood of trauma, taking the context into effect. So again, I want to thank Dr. Green for her questions and Dr. Jane for responding to them, and happy to take any additional questions about the standardized procedure.
I guess before we go into those, should we check for public comment?
There's no longer anyone on the public comment line, commissioners.
Okay. Commissioner Green, how does that answer? I'm not sure. There's a whole series of other questions here, but maybe they don't relate to the pediatric urgent care.
I think I exhausted them. First of all, thank you, and thank Dr. Jane for really this extensive response. I think it's partly my fault for not really realizing there's a wraparound document for other providers, and that this is more holistic. And I was under the misimpression that this was like the main triage that would determine further detail of triage. So I really appreciate the answers, and obviously everything is very well thought out, and all the bases are covered. So thank you so much.
Thank you. I think Dr. Green's other questions, Dr. Chow, may refer to the PIPS report, so I think those are coming later.
Sure. No, thank you. I only, I appreciated the annotations allowing us what was sort of the red line copy here. So, but within that, then I actually had one question in terms of if I were using this, and I'm sure that the staff using it won't run into the same problem I did. In your protocol 5, 6, 7, 8, and 10, in reference to how to treat the fever, it seems to me that under plan, which is item D in the protocols, or at least in the first protocol I was looking at, it begins with administering the drug. Now I'm having a tongue problem. Acetaminophen. Sorry, I kept thinking of Tylenol. I shouldn't do that. See, so and then it says number 2, administer ibuprofen. So if I were just reading this quickly, it sounds like I'm supposed to be administering both. I'm pretty sure you all mean one or the other, I think.
Well, I mean, it is not contraindicated to administer both, but I suspect if you keep reading on number 2 under the ibuprofen, it does give some additional information about, let's see if that answers the question.
Well, it was more a question of use of the protocol. And the intent was to not be sequential or that they were together, but be or, then I don't know. But when I read it, it sounds like I first give the acetaminophen, and then I should consider whether I need to use ibuprofen.
We are very fortunate that Dr. Fuentes Affleck is on. I don't know when the last time is she read through this standardized procedure in detail, but she may have some insights about that.
Yes, thank you. I would say that it is not uncommon for us to give acetaminophen, wait 30 minutes or so to judge the response. And then if there isn't a sufficient response, to give ibuprofen. I am not looking at the wording of the standardized procedure, but we do use both of them in combination. Some children respond better to one than the other. And often because children are more likely to have febrile seizures than adults, we are always wanting to get that temperature down if it's super high. So that would be a typical response for us. But again, I don't have the exact wording. Lisa, I hope I'm not contradicting anything in the standardized procedure.
I don't think you are.
Yeah, no, I don't think so. If that, it's actually a good explanation of not putting or in and, but to leave it this way, if that is something that is within the practice of the, well, in this case, the registered nurse, right? In that, then that helps a great deal. Thank you. That you actually can use both, and that allows that if temperature is not responding well, then here's another option to see that it drives down. So if we look at it that way, then it makes sense. Sure.
I would also add that there's, in our urgent care clinic, there's a lot of communication. So it would be quite common for the nurse to come to the attending and say, here's where we started, here's the response, what do you think? I'm planning to give ibuprofen, and the attending would say, yes, that sounds like a good idea. So people don't operate totally independently. They can, but there's a lot of back and forth and sharing of information.
Okay, well, no, that's great. Thank you very much. That was a handy explanation, and also allows me to understand, at least in pediatrics, the use of both the acetaminophen and ibuprofen within the same setting. Are there any other questions, or we can take up actions that you would like us to take up?
I have two more things that I need to present for your
Oh,
consideration
okay.
for action, but my hope is that they will be shorter.
Okay.
So the first one, and these actually have relevance with respect to the survey that Adrian mentioned. So we had the surveyor who looked into medical staff issues, was very diligent and made a number of helpful comments that we took under advisement, even though they won't necessarily be findings in the survey results. One was that in the Department of Surgery core privileges, there was language that said that what they could do included, but was not limited to, the following list of procedures. And the surveyor, thought that that was really a bit general. But he recognized that, it's a trauma center, and that, some procedures are not done that commonly, and that if you're approaching a patient with trauma, you actually might need to, perform things that have not been specifically enumerated in the privileges. So with a lot of consultation with the chief of surgery, that language was updated to include other procedures of similar technical complexity and requiring comparable skills, and emergency procedures to protect the safety of the patient, which seemed to better capture the types of things that our surgeons might do with respect to the surveyor's comments. And we will point that out to them when they come back to make sure that that works for them as well. In addition, the laser surgery privilege has been reformatted as a standalone privilege under plastic surgery. So those are the two items on the surgery privileges list. And then the last item is that for our certified registered nurse anesthetists, our CRNAs, Dr. Gelb, the longstanding chair of our credentials committee, helped explain this to us at MEC. So, for some reason, there's been a bit of a hole for the CRNAs with respect to scope of practice, because there's no regulatory requirement for them to operate under standardized procedures. But traditionally, we haven't had privileges for our affiliated medical staff, only for our medical staff. And when the surveyor came, this, and this has apparently been discussed many times over the years in credentials committee, but because there wasn't, regulatory requirement to do it, a document regarding scope of practice was not formalized. And the surveyor thought that we really should have something formal. We all agreed with that. And so there are new laws in California that will allow privileges for nurse practitioners, for example. And so we thought that it would be appropriate to have our CRNAs, inaugurate that. And so privileges have now been drafted for them, pending your approval. They're quite similar to the privileges that the anesthesiologists have for caring for patients in the OR, except of course they stipulate that the CRNAs will be practicing under the supervision of the attending anesthesiologist.
Very good. Great explanations, and we'll find out if Commissioner Green has any questions related after that explanation.
No, that was really clear. Thanks so much. How many CNRAs do you have?
Oh, that is a great question. I will have to ask. I don't know. We have a good number, but I don't know exactly how many.
Okay.
I
Not
believe it's
enough.
15.
I heard someone say at least 15. So that's Luke. Thank you. That sounds right.
Great.
Okay. Let's see. I think we're prepared for a motion to accept the recommendations,
So moved.
and I would second that.
Thank you both. We will take that as a passage of these, and we can move on to item. Thank you, Dr. Winston. Item 8 is other business.
Yes. Is there any other business for us to consider?
There's still nobody on public comment.
Okay. So we can move on from 8 through 9, and
At 9, there's nobody on the line, so there's no public comment, and we can move to item 10, which is the consideration of a closed session.
so is your motion for consideration of a closed session?
So moved.
And I would second. So Mark, do your magic.
Sure. Please give me about a minute, and I'll take us over there.